Hello and welcome.
Thank you for having me today. My name is Stefano Pallanti. I'm professor of psychiatry at the University of Florence and director of the Institute of Neuroscience, where I develop since the last 10 years a close-up-in clinic for treatment of resistant schizophrenia, and I've published some of this data on a manual that I published for American publishing with John Lauriello, and I spent a year in Davis working with Cameron Carter on first episode of schizophrenia.
Why is it critical to treat the negative symptoms of schizophrenia?
Negative symptoms are the most disturbing part of a schizophrenic spectrum disorders, and they rise as the first symptoms and they can make difficult to define the diagnosis, as well as to communicate the diagnosis to other colleagues, because they can be confounded with depression or with cannabis-induced flattering of mood. And so the first issue is make a good assessment and definition of the diagnosis. Then you have to consider if you have primary or secondary to, because some kind of negative symptoms rise as a response and coping to positive hallucination and delusional experience, and that makes the treatment very different. And then is a challenge because we are just now developing new compound oriented to the treatment of this specific dimension, because the dimension is probably the high burden of a disease, and so it's really an unmet need.
What are some of the determinants of cognitive and functional impairments in schizophrenia?
So in schizophrenia, as much as all the rest of the psychiatric condition, we are now far beyond the just medical model that involve symptom reduction as a main aim of the treatment. In schizophrenia, we want the patient to be functional in his own word, and therefore we have to make, since the beginning, a functional assessment and cognitive assessment, and then we have to monitor during the treatment in order to make the patient functioning in his own environment, in activity like self-maintenance or social activity, make the patient through a social training understanding his own emotion, communicate his own emotion, and be part again of the world after the psychotic breakdown.
What are some of the treatment options that are available for schizophrenia right now for negative symptoms?
The story of antipsychotics starts in age, at the very beginning of the 50s, where we don't even have discovered the dopaminergic system. So it was based on just serendipity, and the aim was to reduce the agitation of the patient. Then only after the appearance of clozapine, we started with a second generation with a profile of action more broadened, not just blocking the dopaminergic system, but modulating some part, fast dissociation from the blocking of the receptors. And then only recently we have a third generation designed on what we know of the intersection between cognition and motoric aspect, reward and attentional functioning, and this new compound might be work better, and we have already some proof of that, some recent approval, and therefore we are still waiting for confirm, but that is a potential new area of clinical activity. Then other options beyond antipsychotic may be represented by antidepressants. There is a long story on that. And some of the glutamatergic agents also show some interest in the treatment of this very problematic dimension of the disorder. But the final important remark is that now 80% of the clinicians believe that recovery can be a realistic goal in schizophrenia. That is something to keep in mind.
Thank you for providing your expertise.
Thank you.